University of Idaho. She's going to be talking today on demonstrating the CHEMS value through business analytics. Can everybody hear us okay?
Yes.
Yes.
Okay.
Yes.
Yep.
Thank you. Just as a reminder, please self-mute just so to avoid any unnecessary background noise. And so I'm going to turn it over to Shin Han now and start.
Okay. Good afternoon, everyone, and thank you, Madeline, for the introduction. And I'm very honored to talk to you guys about how to demonstrate CHEMS value through business analytics. And there's a lot of a discussion about the methodology that to be used for demonstrate the value. Some of those talk about this economic modeling or business modeling or impact study. Business analytics is one of the methodology that I'm going to demonstrate today that can be used to demonstrate the value and then do the analysis. So for today's webinar, I'm going to cover the challenges and opportunities of CHEMS business environment. And right after that, I will briefly introduce the business analytics. Some of you might be very familiar with this term, some might not. So I will do a very brief, what we call analytics 101. And after that, I will use this methodology and using two examples to demonstrate and how to use this analytical approach to reveal the value and the cost associated with operations. So traditionally, EMS business model is purely focused on responding quickly to serious accidents and critical emergencies. But as recent reports state that patients are increasingly call 911 for less severe or chronic health conditions. That creates a kind of a mismatch between the capability of existing EMS system and the demand from those kind of non-emergent and unscheduled medical cares. Now, in terms of a payment model associated with EMS or CHEMS model, typically the payment model is a fee-for-transport model. This type of model does not adequately account for the non-transport cost and the additional cost for readiness. So as some of the national statistics indicated that reimbursement rate for fee for transport also failed to match the cost of the service. Nationwide average for reimbursement rate for Medicare and Medicaid service, this is about 60%. And then for most of CHEMS operation, their lack of sustainable funding. So these are some of the challenging issues that currently EMS and the CHEMS agency are facing. But at the same time, we do see some opportunities arising. One particular opportunity I would say is the Triple M framework that proposed by Institute for Healthcare Improvement. This framework states that it is possible to simultaneously improve the patient experience, reduce healthcare costs, and improve the population health. And in a way that it starts to focus on systematic view of healthcare optimization. At the same time, we also see new payment model has been introduced, fee for quality, value-based payment model. All these models start to reward providers and hospitals who keep the patients healthy and treat problems efficiently and effectively. In addition to that, we also see the evolving evidence-based performance measure from various funding agencies and payers. So given the opportunity and challenge that we're facing, I would say it's a great time to kind of explore using business analytics and some data-driven methodology to analyze the operation and to reveal the value and the cost associated with CHEMS operation. So let me just kind of introduce business analytics a little bit here. It's a very generic term. Business analytics basically includes all the methods and techniques such as statistical, financial, that can be used by organizations to measure performance and to support decision making. Some of the methods that kind of broadly used, such as break-even analysis, financial efficiency analysis, etc. Now, when we decided to use business analytics, the process is very straightforward. First, we identify the problems. What are particular problems we are looking at? And then, related to this problem, we will ask a bunch of questions. Based on the questions asked, and we will start collecting the relevant data and analyze the data, then draw conclusions. One of the examples I want to talk about is this is a problem that asked by some of my contact person here, and they said how to make the payers pay for CHEMS service. Now, this is a very broad question, and related to this problem, let's pick up one of the services that CHEMS agencies have provided, such as assessment and navigation to alternative destinations. So related to this type of a service, I would ask, how does the service save for the payers? And what is the unit cost of the service? And how to reduce the cost and increase the value for all the stakeholders. My next step will be, based on those questions, start to collect the relevant data. Now, those data can be found in your financial statement, such as balance sheet, income statement, and also it can be found in your operational data, such as number of employees you have, the major resources that you use. Now, we also can look into the national statistics. So I have to mention that it is perfectly okay if your data is not complete. I don't know if it's reassuring to say that nobody's data will be complete. So as long as we have some basic data, make some intelligent judgment or assumptions, and we can put the analysis. So here I present an example. This is actually adopted from Matt Zawadzki's presentation, and I extended to that analysis a little bit. So here we try to demonstrate the potential cost savings of assessment and a navigation to alternative destination. Now, keep in mind that we don't have any particular services, particular agency's operational data. So we use national statistics. And according to the HCUP data, HCUP is the Healthcare Cost and Utilization Project database. It has very extensive utilization procedural data. So in 2011, nationwide, there's about 131, how many zeros there? It's a million. 131 million ED visit, emergency department visit. So according to CMS's report, on average, each visit costs about $969. So in total, we can figure out the national ED expenditure. And also, based on the national statistics, 17% of EMS ED arrival, 17% of the ED arrival are through EMS. So we can figure out the percentage that associated with EMS ED expenditure. After EMS send the patient to the emergency department, some are discharged, some are routed through alternative destination. Among all those EMS arrivals, about 15% are routed through alternative destination. So we can figure out the total number of ED patients referred through EMS. This is about more than 2 million patients. Each patient accounts for $969. So that's the potential emergency department savings that generated through this particular service. Now, if we incorporate the U.S. population, we can figure out the population-based ED visit rate, which is about 0.4. So let's say that if we're targeting a urban area with 100,000 members for that particular payer, based on the national data, we can figure out that roughly the EMS service or this assessment and navigation to alternative destination service could save the payer about $606,244 in a year. And if we're target to an area with less population, let's say that this payer has 20,000 members in the service area, and that roughly translated to $122,249. Now, I want you pay a particular attention here that we figure out those numbers without any operational data. This is purely based on national statistics. And with this number, I think we have some, a tangible number that to start with for discussion and collaboration. Another example I'm going to show you. So forgive me about all the tables. When I teach, my students always complain about tables. So, but here I think probably, showing the table that we can demonstrate the process more clearly. This is a break-even analysis, and thanks to the Ada County EMS service, they provided me their annual operation report. So I just using their operational facts data. So there are about 28,000 total calls that happened in 2016, and they have 28 ambulances. On an average day, they will staff about 9 to 12 ambulances. Each ambulance will staff 2 crew members, and they have a total of 13 stations. Their total employee is 139 people. And I also have their revenue data for 2016 and expense data. Now, on the revenue side, their main revenue comes from tax and fees, patient payment, other payers, and then other income. Their expense mainly comes from capital equipment and operating expense and the salary and benefits. So based on these information, I want to mention that the total operational facts, revenue data, and expense data are come from the EMS agency. Then based on those data, I figure out that on average, the salary and benefit per person is about $70,103 per person. So let's look at their ambulance cost. Without considering the ambulance purchasing and maintenance cost, just focusing on the staffing cost, I figured that each day they spend about $5,000 to keep the crew of ambulance. Now, I highlighted this daily expense here, and I want to say that this is a fixed cost. It's not a variable cost. Very often, when we look at the cost structure, people will say, hey, personnel cost, it's a variable cost. No, in this type of operation, this cost is a fixed cost. And then let's assume that on average, when we dispatch an ambulance, how far is the distance and how much does that cost? I assume that on average, they will drive 30 miles maybe. And let's say it costs $2 per mile for us to charge for the variable cost. So that translates to, let's say, just $60. Now, I did a break-even analysis based on these facts and these data. So in this analysis, on the left side of the slides, I have shown that as number of dispatches increase, the cost significantly reduce for dispatching the ambulance. And then also, I show this type of data in a chart format on the right side of the slides. So let's look at the data here. If we dispatch once a day, now keep in mind that they have 12 ambulances in their station. So if we just use ambulance once a day, that costs us $5,064 for the dispatch. As we gradually increase the usage of ambulance, the marginal cost or the unit cost of dispatch, which include fixed and variable costs, reduces significantly. Now, if we have 12 ambulances, right? So if we use each ambulance once a day, that is about 12 trips in a day. And that brings the unit cost or each dispatch cost to about $500, $477. So you see that the cost reduction is significant here. Now, I show this, want to demonstrate that for a resource that very high in fixed cost, when we try to reduce the cost, actually we have to use them more. It could be counterintuitive, but the cost saving is really come from the increase of volume or increase of the usage. Now, of course, we also, this analysis needed to be fact checked. For one, we needed to talk about is that feasible to dispatch 12 times a day? Is that creating too much burden to the staff? So this is I want to say this is just a starting point and show us the cost structure and how it can be reduced. Further analysis can add to that, and then it will bring out more insights about their operation. So along that line, we can ask additional questions, such as what is your average patient charge? What is the highest one and what is the lowest one? And what is your amount collected per transport? What is your collection rate? Any additional service provided before, during, and after the transport? Who is your largest payer, and what is your payer mix? In terms of the target audience, who do you want to talk to? Is that payer or policymaker? What is the annual cost of operating your CHEMS program? What is the annual revenue that CHEMS program generates for your agency? How does your CHEMS program receive payment? And what is the overhead that must be built into your program? All those questions leads us to a better understanding of the operation and the operation efficiency, and which will, in the end, lead us to a better decision making in terms of the payment model and then reimbursement structure. So, and with the result from this analytical process, I would say that CHEMS agency can talk to the payers and the hospitals for additional collaboration agreement. Payers typically interested in cost-effective healthcare service under the umbrella of CHEMS, and then services such as mobile care, patient navigation, and others can be subsidized. And hospitals are particularly interested in reducing hospital readmission. Services such as post-discharge follow-up can be subsidized. So these are just, some two very simple example I'm showing here. In the end, I want to say that it is okay to use national statistics as a reference, referencing performance data and a cost estimation. Data, when we talk about data, everybody will say that how I don't have enough data, but we have to be creative and using the readily available data out there and then to build a model around that. And for capital intensive resources, such as the ambulance and some agency might have a helicopter, increase the usage actually will reduce the marginal cost, which is the per unit cost. So the practice could be counterintuitive, but that's a way to significantly reduce the cost. And additional financial and operational analysis can be done. There are many analysis out there, such as the financial efficiency analysis. And these analysis can identify value and contribute to the sustainability of the program. So if you have a question or you are interested in this type of analysis, I would recommend you to contact Madeline Russell, who is the Regional Collaborative Project Manager of the SHIP. Now I will hand the conversation back to Madeline.
All right, thank you. I'm going to unmute the lines. If anybody has any questions for Dr. Xu, please let us know. We are looking at a potential pilot project for doing economic modeling or business analytics at the agency for a summer project that we've kind of touched on a couple months ago at a work group meeting, and we've had interested agencies so far, but we are still looking at doing that. So if anybody's interested in that, again, please contact me for more information. But I'm going to go ahead and open it up to participants, and please let us know if you have any questions or anything regarding business analytics or economic modeling for Dr. Xu.
Hi, this is Rhonda Robinson-Beal. I just want to compliment Dr. Xu on her approach to modeling. I think it makes logical sense, and certainly all the variables that are really needed to begin to present a value-based approach and value-added approach with payers definitely is there. I just want to make one comment. On your first slide with the analysis, when you're using the HCUP data, I just wanted clarification. Is that HCUP data using Medicare only, or is it Medicare and private payer? Because there is such a difference between what Medicare reimburses and what private payers reimburse, primarily because Medicare puts a ceiling on cost, and many times that's below operational costs, and so the cost gets shifted to the private sector.
Hello, Dr. Robinson. Yes. So for HCUP data, I think it's a comprehensive approach. I think it includes Medicare and the private payers.
So that's an average cost for Medicare and private payers. When I'm
yes,
you're 900. Yes. Okay. And then the other question is whether or not, because I wasn't sure I saw this, whether or not there was in the analysis taking into account geographic distance. So obviously in Boise, the geographic distance is going to be much smaller than it would be in a rural area where one may be traveling several miles to deliver a service, which could have an impact on the maximum number of services that can be delivered.
Here in this analysis, we haven't included distance. It's more just national average data. So in HCUP data set, it also has a state level data, but unfortunately, Idaho doesn't have the data there. So state for Idaho data is empty, that particular section.
Okay.
So we are in discussion of using other states' data as a reference if we really decided to go to the details of, geographic-based analysis.
Again, I just want to compliment you on the extent of this business analysis. It was very, very well done.
Thank you.
This is Kevin Gray from Blackfoot Fire Department. Back when the CHEMS project started, we were kind of under the impression that all the hospitals would be penalized for readmissions and stuff like that, and we found out during the program that critical access hospitals aren't being penalized, and so there's really what I found out, there's really no motivation for the hospitals to get on board with this CHEMS project.
Sorry, I'm not very familiar about that. Maybe Maddie can comment on that. No?
We could probably reach out to Stephanie, Chief Gray. She does a lot with community access to hospitals. So she could probably at least give you an idea. I thought I heard a rumor that that was something that was going to start happening in the future, but she'd probably be better to speak to about that. And I can forward you to her or send her contact information to you, either way.
Perfect. That'd be great. Thank you.
Yeah, no problem.
I do have a question on, so for your break-even analysis for ambulance usage, typically a CHEMS visit doesn't include ambulance. It's more of just, a personal vehicle to go out to the patient's home. Can this business analytics model be modified to include those type of visits? And
excellent question. So for this type of analysis, as long as in the cost structure, there's a larger portion of a fixed cost. Let's say for the home visit, you have 2 staff visiting that site, and staffing cost is the main cost in that total cost. Their traveling cost, and they get paid by their salary and then probably travel per diem on that day. So their fixed cost is the salary that you pay to these 2 staff, 1 or 2 staff. So that cost is probably a major portion of the overall cost for that visit. So as long as there's a large fixed cost associated with any kind of operation or resource, and we can look into that and how to find this optimal visit point. How do we schedule that? What will be the optimal break-even point for the agency to provide that service? So it's really look at the cost structure, the fixed cost and the variable cost. And the fixed cost could be, sometimes we think it's variable cost because it's a staffing. It's really, a fixed cost if you are paying the salary.
thank you. Is there any other questions from anybody on the phone?
Are you going to be able to send out the PowerPoint so we can go back through it and see the entire layout of the stuff? Because I think some of it's cut off on the bottom.
Yes, I will be posting the PowerPoint slide and also the recording to the webinar on the SHIP website, and I can send out that link when it's uploaded.
Perfect. Thank you very much.
Is that you, Bill?
Yes.
Hey, Bill, it's Martha. I can also send you the slides too, whatever is easiest for you.
Okay, thank you.
You bet.
Hey, Marta, this is Les. I'd like to have a copy of those slides too, if you would, please.
Sure thing.
All right, well, if there's no additional questions, we can go ahead and wrap up. After this webinar, a survey will be sent out to everybody just for some feedback on the webinar. And if there's anybody that's interested in learning more about business analytics and economic modeling for your CHEMS agency, please reach out to me, and we will get you in touch with Dr. Shu in the future. So.
And just a reminder, if you're wanting CEs, make sure to fill out the survey.
Thank you. All right, if there's no more questions, we'll go ahead and wrap up. Have a great day, you guys.
Bye. Thank you.
Thank you very much. It was a good webinar.